Have you ever opened your medicine cabinet, looked at those little bottles lined up in a row, and thought, these are keeping me alive? What if I told you that some of those very pills, the ones millions of older adults take every single day, have been quietly linked to an increased risk of heart attack and stroke? And here is the hard truth. Most people taking them have no idea. If you are over 55, if you take medication for pain, sleep, anxiety, blood pressure, or inflammation, this could directly affect you. Not someday, now. Today, I am going to walk you through 5 commonly prescribed pills that cardiologists are increasingly concerned about, especially in adults over 60. You will learn why these medications can stress your heart and blood vessels, who is most vulnerable, what warning signs to watch for, and most importantly, what safer, smarter alternatives you can discuss and implement. Some of these may surprise you. Some may already be sitting on your nightstand. My name is Dr. Lauren Hayes. I have spent years studying the relationship between commonly prescribed medications and cardiovascular health in older adults, working with grandparents, retirees, former athletes, teachers, business owners, good people who did their best to stay healthy and still experienced preventable cardiac events. And over the years, I noticed a consistent pattern. Many of them were taking medications that, while helpful for one condition, were silently increasing strain on their cardiovascular system. Not because they were careless, not because their physicians were negligent, but because medicine is genuinely complex, and sometimes risks are underestimated, especially in older bodies. As we age, our kidneys filter differently, our arteries stiffen, our blood becomes more prone to clotting, our hearts do not tolerate stress the same way they did at 40. A medication that is generally safe at 45 can behave very differently at 75. So today, let us talk about what you deserve to know. Let us start with one of the most common culprits, pain relievers that are not as harmless as they seem. You wake up with stiff knees, your lower back aches, your shoulder does not move the way it used to. So you reach for something like ibuprofen, naproxen, or diclofenac. These are NSAIDs, non-steroidal anti-inflammatory drugs. They are everywhere, over the counter, easy, familiar. But here is what most people do not realize. NSAIDs do not just reduce pain, they also affect how your blood vessels function. They can cause fluid retention, they can raise blood pressure, and they can increase the likelihood of blood clot formation, especially in older adults. Multiple large-scale studies have shown that certain NSAIDs are associated with a higher risk of heart attack and stroke, particularly when used regularly or at higher doses. Why? Because they interfere with prostaglandins, chemicals in your body that regulate inflammation but also maintain healthy blood flow and protect the lining of blood vessels. When that balance shifts, blood pressure creeps up, arteries constrict, platelets become stickier. Imagine Mr. Harris, 72 years old, active, walks daily. He starts taking naproxen twice a day for chronic knee arthritis. Within months, his blood pressure rises by 10 points. He does not notice. He feels fine. Until one afternoon, he experiences chest tightness during his daily walk. Was the painkiller the sole cause? Probably not. But did it contribute to increased cardiovascular strain? Very likely. I am not saying never take NSAIDs, but daily long-term use in adults over 60 needs careful evaluation. If you need pain relief, frequently consider these strategies. Use the lowest effective dose for the shortest duration possible. Explore physical therapy to strengthen joints and reduce inflammation naturally. Try topical anti-inflammatory gels instead of oral pills. They have significantly less systemic absorption. Incorporate gentle anti-inflammatory habits. Walking, omega-3 rich foods, weight management. Your heart should not be collateral damage for joint pain. Now let us move to something even more surprising. Certain sleep medications. Sleep becomes harder as we age. You wake up at 2 a.m., you stare at the ceiling, you start counting regrets instead of sheep. So your doctor prescribes something to help you fall asleep, maybe a benzodiazepine like diazepam or a Z drug like zolpidem. They help at first, but here is the concern. These medications can depress the central nervous system. They can lower blood pressure too much at night. They can cause irregular breathing patterns. And in some studies, long-term use has been associated with increased cardiovascular events. Why would a sleep pill affect the heart? Because your heart and brain are deeply connected. These drugs can alter autonomic nervous system balance, the system that regulates heart rate, blood pressure, and vascular tone. In older adults, this balance is already more fragile. Add a sedative that slows everything down, and you may increase the risk of falls, nighttime oxygen drops, arrhythmias, and even stroke. Mrs. Delgado, 78, started taking a sleep aid after her husband passed. She felt groggy every morning. One night she got up to use the bathroom, felt dizzy, and fell. A fractured hip, hospitalization, reduced mobility, a cascade of complications that changed her independence permanently. Sedatives do not just affect sleep, they affect stability, circulation, and brain oxygenation. Better options. Prioritize sleep hygiene, dark room, cool temperature, no screens an hour before bed. Magnesium glycinate under medical supervision can help some people relax naturally. Cognitive behavioral therapy for insomnia has shown consistent long-term success without any drug side effects. Sometimes the safest pill is no pill at all. Now let us talk about something many heart patients are genuinely shocked to hear: certain decongestants and cold medications. You catch a cold, your sinuses are blocked. You reach for a decongestant containing pseudoephedrine or phenylephrine. You want to breathe again, but these medications work by constricting blood vessels. That is precisely how they reduce nasal swelling. The problem: they do not only constrict vessels in your nose, they constrict arteries throughout your entire body. Blood pressure rises, heart rate increases. For someone with stiff arteries, existing plaque buildup, or borderline hypertension, that temporary spike can trigger something far more serious. I have reviewed cases of patients with well-controlled blood pressure who experienced dangerous elevations after taking over-the-counter cold remedies. They thought, it is just a cold pill. But the cardiovascular system does not care which aisle of the pharmacy it came from. If you have heart disease, high blood pressure, or are over 65, avoid systemic decongestants entirely. Instead, use saline nasal sprays. Try steam inhalation, use a humidifier, choose antihistamines that do not raise blood pressure. Sometimes the simplest remedies are genuinely the safest. Now here is one that may be controversial: certain hormone therapies. Hormone replacement therapy, especially estrogen with or without progesterone, has helped many women manage menopausal symptoms effectively. But large clinical trials have shown that in certain age groups, particularly women who begin hormone therapy many years after menopause, there may be a meaningfully increased risk of stroke and blood clots. Why? Because estrogen influences clotting factors. It can make blood slightly more prone to coagulation. In younger women near the onset of menopause, the risk profile may be quite different. But in women over 60 or more than 10 years post-menopause, the cardiovascular risk increases in ways that deserve serious consideration. Timing matters. Dosage matters. Delivery method matters. Transdermal patches may carry lower clot risk compared to oral forms. If you are on hormone therapy and over 65, it is worth having an honest reevaluation with your physician about whether the benefits still genuinely outweigh the risks for your specific situation. And finally, certain stimulant medications. This includes some medications prescribed for attention difficulties, persistent fatigue, or even weight management. Stimulants increase heart rate, they elevate blood pressure, they increase sympathetic nervous system activity, your fight or flight response. In a 30-year-old with healthy arteries, that physiological response may be well tolerated. In a 75-year-old with existing coronary plaque, that is an entirely different situation. Even modest increases in heart rate and blood pressure can meaningfully increase oxygen demand on the heart. If the heart cannot meet that increased demand, chest pain or heart attack can follow. Now, let us address a few persistent myths. Myth number 1: if it is prescribed, it is completely safe. No medication is risk-free. Safety depends on age, dose, duration, and your individual physiology. Myth number 2: over-the-counter means harmless. Absolutely not. Many OTC drugs are powerful pharmacological agents with real systemic effects. Myth number 3: I have taken it for years, so I must be fine. Risk accumulates silently. The body changes. What was well tolerated at 60 may not be safe at 75. So what can you do starting today? First, review every medication you take, prescription and over-the-counter. Write them all down in one place. Second, identify which ones are daily versus occasional. Third, ask yourself honestly, is this still necessary? Is there a lower effective dose? Is there a safer alternative worth discussing? Fourth, monitor your blood pressure regularly at home. Fifth, prioritize lifestyle foundations that reduce the need for additional medications. Anti-inflammatory diet, daily movement, stress reduction, consistent sleep, weight management. Your heart is remarkably resilient. But it does not like surprises. It does not like chronic pressure spikes. It does not like sticky blood. It does not like excess fluid. And it certainly does not appreciate unnecessary strain from medications that were never reevaluated after years of use. This is not about fear. It is about understanding how your body changes after 60 and how medications interact differently with that changed physiology. Let us go deeper. Why aging changes the way pills affect your heart. At 40, your arteries are generally elastic. They expand comfortably with each heartbeat. At 70, they are stiffer. That stiffness means higher baseline pressure inside your vessels already. Now add a medication that slightly raises blood pressure, causes fluid retention, or increases clotting tendency. At 40, the system compensates well. At 75, the margin for error is considerably thinner. Kidney function also declines gradually with age, even in otherwise healthy adults. And your kidneys are responsible for clearing medications from your bloodstream. If a drug lingers longer than intended, its cardiovascular effects become amplified in ways that were not anticipated when the prescription was written. There is another factor that rarely receives adequate attention: polypharmacy. Simply put, taking multiple medications simultaneously. The average adult over 65 takes 4 to 8 prescription medications daily. Each one may be individually appropriate, but together they can interact in ways that increase heart rate, alter electrolytes, raise blood pressure, or promote clotting. And often no single pill receives the blame. It is the combination. Let me give you a clear example. Mrs. Johnson, 74. She takes a blood pressure medication, an NSAID for arthritis, a sleep aid at night, and a decongestant during allergy season. Individually, each was prescribed for a legitimate reason. Together, they create slight fluid retention from the NSAID, periodic blood pressure spikes from the decongestant, and nighttime drops in blood pressure from the sleep medication. Her cardiovascular system is constantly adjusting, compensating, straining. One hot summer afternoon, she becomes mildly dehydrated, her blood thickens slightly, blood pressure fluctuates, and she experiences a transient ischemic attack, a mini-stroke. Was it one pill? No, it was cumulative layered stress. And that is the pattern I want you to understand clearly. The aging heart does not usually fail suddenly. It fails under accumulated strain. Let us discuss another category that frequently goes unexamined: certain acid reflux medications, proton pump inhibitors. Drugs like omeprazole and esomeprazole are widely used for GERD and chronic heartburn. They are effective for their intended purpose. But long-term use has been associated in several studies with potential increased cardiovascular risk, particularly in people who already have existing heart disease. The mechanism is not fully established, but credible theories exist. One centers on nitric oxide, the molecule that helps blood vessels relax and maintain flexibility. Some research suggests PPIs may interfere with nitric oxide production pathways, gradually reducing vascular responsiveness. Another concern is magnesium depletion. Chronically low magnesium levels can trigger irregular heart rhythms. For many patients, PPIs are genuinely appropriate and necessary, particularly with a documented history of ulcers or severe esophagitis. But if you have been taking one every single day for 10 years simply as a precaution, it is worth honestly evaluating whether targeted lifestyle changes could reduce your dependence. Weight reduction, smaller evening meals, eliminating late-night eating, elevating the head of the bed. Sometimes the most effective solution is a shifted daily habit rather than a continued prescription. Now let us address a category that consistently surprises people: certain diabetes medications. Diabetes itself dramatically elevates the risk of heart attack and stroke. Controlling blood sugar is therefore essential. But not all diabetes medications carry the same cardiovascular profile. Some older medications were found to increase fluid retention or elevate heart failure risk in susceptible patients. Others have been shown to meaningfully reduce cardiovascular events. The critical point is this: not all drugs within the same therapeutic category behave the same way inside an aging cardiovascular system. If you have diabetes alongside heart disease or significant risk factors, your specific medication choice matters far more than most patients realize. Modern cardiology and endocrinology now prioritize cardiovascular protective medications when clinically possible. But that only happens when the conversation between patient and physician is informed and specific. You should know exactly what you are taking and precisely why. Now let me shift to warning signs because your body nearly always whispers before it screams. Subtle signs that a medication may be stressing your heart, new swelling in your ankles, sudden weight gain over just a few days, particularly 2 to 5 pounds, unexplained shortness of breath when climbing stairs, more frequent headaches without obvious cause, heart palpitations, dizziness when you stand up, worsening blood pressure readings despite consistent medication. None of these should be dismissed, especially if they appeared after starting or increasing a medication dosage. I once reviewed a case of a patient who noticed mild ankle swelling shortly after starting a new anti-inflammatory. She assumed it was simply aging. It was not. Her blood pressure had quietly risen 15 points. The fluid retention was subtle but cardiovascularly significant. Her regimen was adjusted, the swelling resolved, blood pressure stabilized. Small symptoms carry important information. Do not ignore them. Now, let us address the question I know many of you are thinking. If these medications carry real risks, why are they still routinely prescribed? That is a completely fair question because medicine is fundamentally about balancing risk against benefit. If someone has severe inflammatory arthritis and genuinely cannot function without NSAIDs, the functional benefit may outweigh the cardiovascular risk, particularly with careful ongoing monitoring. If someone has debilitating insomnia, short-term sleep medication may be entirely appropriate. The issue is not that these drugs are inherently bad. It is that risk changes with age, with duration of use, with dosage, and with the combination of other medications being taken simultaneously. And formal reassessment of that evolving risk is far too often neglected in routine care. When was the last time your complete medication list was reviewed as an integrated whole, not simply refilled, genuinely reviewed? That single conversation with your physician could reduce your cardiovascular risk significantly. Let us address two more persistent misconceptions. I do not have heart disease, so none of this applies to me. Actually, it does, directly. Many first heart attacks occur in people who had no prior diagnosis. Plaque builds silently over decades. Medication-induced cardiovascular stress can destabilize vulnerable plaque, even in people who believed themselves to be perfectly healthy. Second myth, my numbers look fine, so I am protected. A blood pressure of 128/78 appears reassuring, but if a decongestant spikes it to 160 for several hours repeatedly, that intermittent cardiovascular stress accumulates. The heart and vascular system record and respond to cumulative strain over time. Now, let me give you something genuinely practical, a medication safety audit you can begin this week. Step 1, gather every medication you take: prescription, over-the-counter, supplements. Place them all on the table in front of you. Step 2, write down why you take each one, how long you have been taking it, and which physician prescribed it. Step 3, identify which ones raise blood pressure, which may increase bleeding or clotting risk, and which cause fluid retention. You may not immediately know all the answers, but the process itself forces important awareness. Step 4, track your blood pressure for 7 consecutive days, morning and evening. Write every reading down. Look for patterns. Step 5, notice how you feel after taking specific medications. Do you feel flushed? Does your heart race? Do you feel unusually fatigued? Personal data empowers informed conversation. Let us step back emotionally for a moment, because this matters beyond the clinical data. After 60, your priorities shift fundamentally. You are no longer chasing professional milestones. You are protecting independence, mobility, time with grandchildren, the freedom to travel, mental clarity that lets you stay fully present in your relationships. One preventable stroke can alter every one of those things permanently. One heart attack can limit the decade ahead of you in ways that are extraordinarily difficult to reverse. And sometimes, meaningful prevention is not a dramatic surgical intervention or an expensive new treatment. It is thoughtful medication management. It is the removal of unnecessary accumulated strain from a heart that has been working without pause for every year of your life. Imagine yourself 10 years from now, walking confidently, stable, clear-headed, no cane, no oxygen, no walker. That future is not guaranteed, but it is genuinely influenced by the decisions you make now, including what enters your body every single day. Your heart beats approximately 100,000 times daily. It receives no days off. The very least we can do is stop making its work harder than it needs to be. Let us discuss blood thinners for a moment. These medications reduce stroke risk in conditions like atrial fibrillation. They are genuinely life-saving for the right patients. But combining them with NSAIDs or certain supplements can dramatically increase bleeding risk, including the most dangerous outcome, bleeding inside the brain. The danger is never the blood thinner alone. It is the interaction. Polypharmacy again, layer upon invisible layer of compounding risk. How many different physicians are currently prescribing medications for you? Your primary care doctor, cardiologist, orthopedist, endocrinologist, pulmonologist, each focused entirely on their specialty. But who is examining the complete picture? This is where you become the most important person in your own care. You are the central coordinator. No one has access to your complete medication reality the way you do. No one has more to gain from understanding it. There is a psychological pattern that many women and men over 60 fall into without recognizing it. I have been taking this for years. If it were genuinely dangerous, something significant would have happened already. But cardiovascular disease is cumulative and patient. Plaque does not form overnight. Arteries do not stiffen in a single week. Small, persistent elevations in blood pressure over years quietly accelerate damage that remains invisible until it is not. This is not about dramatic side effects appearing suddenly. It is about long-term strain building in a system with a gradually narrowing margin for error. And here is something genuinely empowering. Small, deliberate reductions in that strain can produce meaningful benefits. Lowering systolic blood pressure by just 5 to 10 points can significantly reduce stroke risk. Reducing chronic inflammation can stabilize vulnerable plaque. Eliminating unnecessary fluid retention can decrease the workload your heart carries every hour of every day. You do not need perfection. You need thoughtful optimization. Let us address another category that frequently goes overlooked: certain migraine medications. Some older migraine drugs work by constricting blood vessels. That vasoconstriction is the mechanism through which they relieve headache pain. But if you have coronary artery disease, even mild undiagnosed plaque, that same vasoconstriction applied throughout the body carries real risk. It is not a common outcome, but it is a real one. And context always matters. The same medication can be entirely appropriate for one woman and genuinely risky for another depending on her vascular health. Two women can take the identical medication. One experiences no adverse effects whatsoever. The other develops serious complications. Why? Genetics, arterial health, kidney function, hydration status, electrolyte balance, existing plaque burden, daily lifestyle. There is no universal reaction. That is precisely why blanket assumptions about medication safety are so dangerous for older adults. If you are over 60, these 5 questions can meaningfully reduce your cardiovascular risk. 1. Does this medication raise blood pressure? 2. Does it cause fluid retention? 3. Does it increase clotting or bleeding risk? 4. Does it affect heart rhythm? 5. Is it still genuinely necessary at my current age and health status? 5 questions. Simple to ask. Genuinely powerful in their implicatio. I have sat with patients after strokes. I have spoken with families in the hours after heart attacks. The sentence I hear most consistently: I wish we had known. Not I wish we had access to a more powerful drug. Not I wish we had a more sophisticated procedure. I wish we had known. Knowledge is not about generating fear. It is about creating options. When you understand your real risk, you can adjust course before the consequences arrive. And here is something I want you to carry forward from today. Many cardiovascular risks are genuinely reversible. Arteries can regain flexibility with consistent lifestyle change. Blood pressure can improve meaningfully. Inflammation can decrease. Even plaque can stabilize. But that only happens when we deliberately remove the unnecessary contributors that have been quietly accelerating the damage. Dr. Lauren Hayes' medication audit checklist for this week. Review your complete medication list. Monitor blood pressure every morning and evening. Hydrate consistently throughout the day. Reduce excess sodium in your daily meals. Walk at least 20 minutes daily. Prioritize genuine restorative sleep without over-reliance on sedatives. Ask your physician directly about dose reductions wherever appropriate. Small steps, consistent steps, compounding results. Do you know your average blood pressure? Not your most recent single reading, your actual daily average? Do you know your resting heart rate? Do you know your current kidney function numbers? These are not medical trivia. They are the essential dashboard readings of your cardiovascular engine. You would not drive across the country without checking your fuel gauge. Do not navigate your 70s without understanding the numbers that govern your most vital organ. Medications are tools, not guarantees, not protective shields. Tools. Used thoughtfully and reevaluated regularly, they protect you. Used on automatic pilot without reassessment, they can silently add the very strain you believed they were eliminating. You deserve a heart that supports your life, not one that is quietly being worn down by the medications meant to protect it. So, tonight when you open your pill organizer, pause, look at each capsule, and ask yourself honestly, Is this still genuinely serving me? Or is it time to have a real conversation with my physician? Because prevention at 60 is substantially easier than recovery at 75. And the heart you protect thoughtfully today is the one that carries you into every tomorrow you are still hoping for. Tell me in the comments, how many medications are you currently taking daily? You may be surprised how many people watching right now share your exact situation. If this conversation has been valuable to you, share it with someone you love, a husband, a sister, a friend from your community. You genuinely never know whose heart your share might help protect before it is too late. And in our next discussion, I am going to reveal the specific blood pressure numbers that cardiologists quietly consider danger zones for adults over 65, even when those numbers appear completely normal at first glance. That is a conversation you will not want to miss. I am Dr. Lauren Hayes. Stay proactive, stay informed, and take care of that remarkable heart.